much. So, I think every doctor has talked about mental health and how it is important, and everybody has to be put on some kind of mental health support. So, mental health, just saying it is only psychological or only emotional, is not the right way to approach it. We have to know how neurobiological changes occur in the brain and what are the neuropsychiatric symptoms that we can identify. So, we are just taking an example case of here. So 38-year-old female, BMI was 34 kilograms per. So the main complaints were low mood, social withdrawal, emotional eating, and poor sleep. There is no prior history of psychiatric disorders. So usually when prior history is not there, that is also an inhibition to refer. Eating pattern is frequent takeout, which we all know after Swiggy and Zomato, binge eating episodes, and a lot of guilt after eating. So, do you think this patient has a psychiatric comorbidity, considering these symptoms, only these symptoms that we have? Yes. So, would you initiate psychiatric medication, or would you prefer that you refer to a psychiatrist? And what are the red flags you would need to see? I guess if you want to answer this, would you refer?
Yes.
So there is a bidirectional relationship between obesity and psychopathology. As we know, obesity causes inflammation, increased cytokines, and intestinal dysbiosis. Then there is dysendocrinism and dysmetabolism. Due to all this, what happens is an unhealthy brain is what happens. Neuroinflammation occurs, which causes microgliosis, and excitotoxicity, which basically the glutaminergic system, and hypothalamic inflammation, hippocampal inflammation, and reduced BDNF expression. This progression of this neuronal damage leads to reduced neuroplasticity and prefrontal cortex anomalies and neuropsychiatric symptoms. There is actual degeneration also that can occur, which leads to neurocognitive decline. So obesity and psychiatric disorders actually influence each other. Because of this synaptic dysplasticity, multiple circuits are affected. We know that hypothalamic propriomelatonin expressing neurons that are there in the arcuate nucleus, they control the energy homeostasis and food intake. This also, as we know, HPA axis influence will be there. Now, what do we mean by energy homeostasis? There is a set metabolic point which our body decides that this is what the weight is supposed to be. So this set point, even after the weight loss, when we don't reprogram the brain to understand to change the set point, it goes back to that. Mostly, maybe this is the reason for most of the relapses. So the mesolimbic dopaminergic system, glutamatergic plasticity, these two together cause changes in the hippocampal region, long-term potentiation, which is basically our memory control, how our memories are formed. Because of these changes, there is a very strong memories that are formed which influence your further decisions. And as we know, opioid signaling, the pleasure pathway, all these things will get activated. And now we know the GLP dysfunction that can contribute. We know that there are both central and peripheral metabolisms that occur. So the appetite regulation and satiety signaling occurs through central and peripheral. Now, psychiatric aspects of obesity. Eating disorders like binge eating disorder contribute to obesity, and nowadays we are seeing binging is everything, not just food, watching series, everything has become like, oh, I am binging. It's become one of those terms which everybody used, and it is normalized a lot. So many people just say that I have such a big packet of chips and some burgers, and I just keep watching and binging. So it's become like you watch TV, you eat food. And family sitting together, eating food is becoming less and less. And so this is a very important thing to observe, and it is definitely contributing to the obesity. Now this is basically driven by emotional dysregulation and also stress and also habituation. Now mood disorders and obesity, I'm sure we all know any kind of bipolar disorder or depression, it contributes to forming the metabolic syndrome, especially with the medications which increase the weight gain. ADHD is also, in the ADHD it is prevalent, we have seen almost 27.4% of the children with obesity, adults or children with ADHD having obesity. And there is also a shared neurobiology because of their executive dysfunction, they cannot actually plan meals and stick to the plan. Even with autism spectrum disorders also, it is very difficult for them to maintain that regular eating habits, and also they get habituated to very high calorie food like sugars and fats. And it's very difficult for parents to adjust to the autistic child and tell, because they like only one particular type of food. To break the habit, it's very difficult. Now, along with this, a lot of cyclothymia is what we see. Like few days you feel good, few days you will feel bad. This is quite normal for a lot of people, but when the lows are very low and the highs are all dysfunctional, yet you cannot function at that time, these kind of temperaments also will lead to binge eating and obesity. This basically promotes impulsivity and maladaptive coping. Now, the cycle of dysfunction and obesogenic behaviors. Now, behavioral dysfunction can occur with affective temperamental framework. Is what affective is basically our mood changes, how we receive the information and how the brain processes. And these traits that are formed predispose to impulsivity and maladaptive coping. So already we know that we like to eat this food. At this time we have to watch and eat food. So this is already a fixed thing. And as soon as we open the phone and see some Swiggy, that impulse to order something comes. When we go to the supermarket, that impulse to buy that high fat foods or high sugar foods comes up. And once this happens and the habit comes, and then next time you feel, okay, you know what, I'm going to go to the fruit, but then your brain keeps pulling you to go and eat the sugars and chips. So this leads to then again emotional dysregulation, cytotonic traits like we have found, and also there is an addictive state. The pathways, the neural circuits that get activated when taking any drug of abuse are the same pathways that get activated when you eat high fat, high sugar foods. And definitely there is a reward behavior that is coming. So the neuropsychiatric dysfunction, if I have to put it in a chart, motivation drives circuit, that is basically your ventral striatum and your dopaminergic system that gets activated. So the motivation is to pleasure. That means if you eat it, then you get pleasure, so then you are motivated for that. And motivation drive is kind of goes hand in hand, because dopamine not just controls your thoughts, it even controls your body and your physical movements also. So even that, like for drug of abuse, we say, pouring the drink in the glass, drinking it, it's all the habit. And it starts from there. So watching the food, cooking it or eating it, the smells, everything, it starts from there. So you have to understand the thought and motivation starts in the brain when the food goes inside, and then the obesity starts. And then there is a reward and salient circuit, which we have our caudate nucleus and ventricular area and nucleus accumbens, your basic serotonergic pathway. So the rewards that you get, a lot of people, I'm sure we know, will work a lot, will have a piece of chocolate. And I personally, whenever I used to finish 5 pages, I used to keep my chocolate there. So that was kind of a very small reward, but then if you have little bit of adjustment or control that, okay, after this I can have fruit, after this I can have veggies, if that kind of attitude we develop, it's okay. But usually that does not happen when you are already habituated with the dysfunctional behavior. Now, inhibition control circuit, that means when we want to stop ourselves. We want to stop ourselves, but that is not happening. That is basically your dorsolateral prefrontal cortex, ventromedial and anterior cingulate, where your motor decisions, your executive functions have to take place. When already your dopamine is pushing you to do something, how will you think about it? How will you plan when already there is a dominance of another part of your circuit? Now, declining and memory circuit, like I have told you, it's basically your amygdala, hippocampus and putamen. Now, amygdala only knows emotion. You're upset, you want to eat. You'll feel happy, you want to eat. So it is like a signal, one-on-one signal that keeps releasing. And because of this, the constant signaling that comes, your dopaminergic neurons and serotonergic neurons concentration wherever they are there, like in the PFC, your dopaminergic neuron concentration is more. So they get kind of like sluggish. I think that is a simple way to say. So the activation that is required is not there. So this is the cycle of dysfunction. Now, what are the diagnostic tools? Like we see in the outpatient, they use usually don't say that, I'm feeling like this, I'm feeling like that. Patients are not usually that expressive when it comes to other doctors or physicians. And usually time is also not there. Usually the pain and weight loss is the primary. If they're having pain, they come with pain. I want to lose weight, but why are you gaining weight? What is happening? They don't want to answer those questions. They are like, I'm like this, I eat, what should I do? And quick solutions, everybody wants quick solutions. So what we can do is, if you have time and you have psychologists, better is to do these scales. You have a binge eating scale, Yale food addiction scale, and this depression and anxiety questionnaire. It is a very simple 21 questionnaire. We'll have few pointers in this category. What is the mood, what is the anxiety level? Depending on that, you can refer. Now, when do you want to refer to a psychiatrist? Most common, sleep disturbances. So sleep disturbances, should you? I think you should, because we don't know what is causing the sleep disturbance. Yes, like all we have discussed previously, it might be just the obese and they are not able to sleep the position, or they have apnea, all these reasons also, but they might be overthinking, they might be watching the phone. That is the reason they're having sleep disturbance. Now watching the phone, overthinking everything, they won't really say it. They won't tell you that, they just say I'm not able to fall asleep. That's all. So then emotional eating, they will tell I eat, and then with guilt. You can eat, sometimes you feel emotional, food is definitely something that gives you a lot of happiness and pleasure. So it's okay, but when you feel guilty and that guilt drives you to eat more, that is what is you need to identify as the red flag. And social isolation. Like I said, eating by themselves, watching TV, not interacting with others, prefers to be just in their room, usually what we see with teenagers also. Self-harm is very important. Nowadays it's becoming very common. Wrist, you can see that they'll have marks, or sometimes they'll have burn marks, or sometimes nowadays I have seen they have on the feet. They wear these shoes, those fancy shoes, and they have on the feet just near the ankle. That is the new thing that I have seen in my OP. Then suicidal ideation if they are expressing, and you have physical signs of bulimia nervosa. When they eat and they vomit, that is bulimia nervosa in a short form. You have dental erosions, and they complain of frequent constipation and diarrhea. Also, multiple failed attempts of weight loss. They usually do crash diets, like taking some kind of nutrition supplement and then just doing the water diet, just that liquid diet and tea diet and all these things. They do the crash diet, they fail, and they express a lot of self-hate. I hate myself for doing this, and I'm not able to maintain. So when they are talking like this, you have to give it importance and do the questionnaire, and at least take some time to refer. And any substance, nicotine, alcohol, cannabis, any substance, because already their pathways are disrupted, the circuits are disrupted. So any substance, even if it is nicotine, which is the most common thing, there is a potential for developing other disorders also. Now, treatment considerations, medication should be started only after severity is assessed. There is no point in starting low dose of medications because they won't work and the patient will feel I'm not feeling better. Then subclinical doses of SSRIs and SNRIs actually have a risk of worsening the symptoms because they take the tablet, sometimes the serotonin level rises and the impulsivity and the activation occurs. So when they have the suicidal thoughts and suddenly we'll give a tablet without any counseling or anything like that, their impulsivity, rather than impulsivity, will go into action. They actually get motivated to do something. And the weight neutral medication, we have very few. We have glutathione, fluoxamine, vertioxetine, desvenlafaxine. These are considered weight neutral, but nothing like they'll help in weight loss. There are so many more medications which cause weight loss, and I'm sure everybody, even every one of you, will be afraid psychiatric medication will cause weight gain. So when that weight gain is the fear, then we need to know how to handle it. Next, benzodiazepines, which are most commonly prescribed by physicians for sleep disturbances, they also cause weight gain because the sedation occurs and the slowness of what occurs in the GABA, the slowness that occurs, their motivation drive can be affected. That is the reason. Even the short-acting benzodiazepines also can cause weight loss in a long term. And antipsychotic drugs, mood stabilizers should not be initiated. Psychotherapy, there are different modalities. You have motivation and enhancement therapy, mindfulness, cognitive behavioral therapy, then lifestyle, life skills development, improving coping skills, meal planning, sleep hygiene, physical activity. All these can be part of psychotherapy. Now, main management plan would be refer to a psychiatrist, monitor mood, sleep and food diary. It would be a very good thing if the patient can maintain a food diary. Usually when they have to write a list of items they ate or do some immediately their emotions get associated with it. So that is a very good idea and key to see how much they are motivated and how much of it they are actually able to process. Then team-based approach is always better to monitor medications and therapy and progress. Thank you.
Yeah,